All right, we're slowing down. Train every person working in public mental health. Pay trainers to go into every child care, preschool, and home care providers to do in-person trainings for all their staff. Yes. Family resource centers and a wellness coach in every school. Ooh, that would be amazing. That would be amazing. Work with governor's office to provide training to all state staff. Very nice. That may be a possibility. If money and capacity were not an issue, but is one thing that you wish the consortium could offer do in the next year. Swag, commercials, billboards everywhere. Mental health awareness and education across Arizona. Provide training to all court staff. Yes. Keep them coming. Keep them coming. What I like seeing how this kind of aligns to this was actually the question. So at the beginning of all of our board meetings, we do kind of a fellowship moment, but a lot of times I ask the board members questions around trauma-informed care, right? But this last one was this, like, what is on our wish list? What are some things that we would like to see? And I can tell you that the board's responses are aligning with a lot of the things that you all are asking for also, which is fantastic. Means we're relatively on the right track as to what the community would like to see also. Mental health awareness and education across Arizona. Preventative supports to all families. Oof, wouldn't that be amazing? Richard infused trauma-informed practice and teacher curriculum at universities. In-person meeting with coffee and pastry. Yes, so our training group is starting those also, having that in-person meeting connection kind of piece. A big media campaign with education opportunities. Love that. Love that. All right, well, we have a busy morning. But I'm really super excited about our presenters today. So, you know, for those of you who have been with the consortium for a long time, you may remember that about 4 or 5 years ago, well, probably more longer than that, I don't know, 2020 happened, and it's like it stopped. It's like everything is, yeah, still 2020, like we've never moved on from that. But we co-hosted one of our summits with the Governor's Office of Youth, Faith, and Family. And former Governor Doug Ducey and his wife were there and had announced that they wanted the state of Arizona to become a trauma-informed state. And that was really super exciting for us, right? Like to have that piece. And what that meant was he had asked the state agencies to look at what does it look like to become a trauma-informed agency, and had kind of asked them to become that. DHS at the time was the organization who like really kind of delved into that, created this large plan, and then the pandemic happened. And we haven't heard anything from that since that, right? But they have been busy at work. And so I'm super excited that Darlene, Depina, Shipp, and Ben Seward here from DHS to talk about the work that they have been doing to become a trauma-informed state agency. Super excited to be able to share with all of you. And then also we will have Dr. Amy Shoptaugh from Phoenix Children's Hospital Center for Resiliency and Wellbeing to talk about the trauma-informed pediatrician training that they have launched in this past year as part of our Maricopa grant also. I think we don't talk about all of the amazing things that Arizona is doing enough. And so I really wanted to use today's quarterly meeting to highlight what is going on in Arizona. So we have the presentations, and then we have committee and partner updates. We have our board update of what it's looked like the past year for us. And then we have announcements that's really just kind of talking about all of the wonderful pieces that we have in Arizona, all the things that are going on. super exciting. But since we do have that busy time, Darlene and Ben, I will pass it over to you. You all should have the ability to share your screen. So I'll stop sharing mine.
Thank you so much, Angie, for the introduction. I'm very excited to share about share the ACEs prevalence based on the latest data set available, and also ADHS ACEs action plans that we have. So I'm going to share my screen now. Are you all able to see it? Okay, awesome. My name is Ben. I'm a senior epidemiologist in the Bureau of Assessment and Evaluation in ADHS. My work primarily focuses on the Youth Risk Behavior Survey and also ACEs surveillance system. And I'll be talking about ACEs prevalence and the ADHS action plans. And then my colleague Darlene will talk about trauma-informed initiative, surviving to driving, the transition ADHS into the trauma-informed agency. So my presentation title is Creating a Safer Future, ADHS ACEs Action Plans for Arizona. Objectives for the presentation is to provide an up-to-date overview of ACEs among children ages 0 to 17 years and to share ACEs action plans. All right, so when you think about your childhood, you know, like the childhood is very, very critical stage of life. There are a lot of physical and emotional and mental growth happening. And we all know that every child deserves nurturing and happy childhood, but unfortunately, not every child has that opportunity to experience positive childhood. And we all know that ACEs is very, very prevalent according to CDC definition of ACEs. So ACEs are potentially traumatic events that occur from 0 to 17 years of age. And there are many, many categories. You probably have seen this a million times before. But ACEs really include abuse, neglect, and household dysfunctions, physical, emotional, sexual abuse, and physical, emotional neglect. And then the household dysfunctions could be living with someone with mental illness and witnessing mothers treated violently. And then latest literature also include bullying as part of ACEs, and also sexual discrimination against sexual orientation, yeah. But these are the major categories that are often discussed in the literature, and also population-based survey. If you look at the data, so this is based on the 2020-2021 National Survey of Children's Health, which is parent-reported data. This is just general about general children population. So overall, ACE scores are higher in Arizona's children than in the national sample. As you can see, the orange bars represent Arizona children, and then the blue bars represent the national average. About 20% of Arizona children from 0 to 17 years have experienced 2+ ACEs, as opposed to 17% in national average. If you look at individual ACE prevalence, these are also higher in Arizona children than the national sample. The most prevalent one is parental divorce and separation, which was experienced by 25% in Arizona, and followed by household poverty, household mental illness, household alcohol, drug use, incarceration, and witnessing domestic violence, and so on. The least prevalent one is discrimination against sexual orientation, but as you can see, 1/4 of 1/4 of children are experiencing parental divorce and separation. So ACEs are also common in Arizona adolescents. So this is based on the Arizona Youth Reported Survey, which is called Youth Risk Behavior Survey. The difference between the National Survey of Children's Health is that National Survey of Children's Health was reported by parents, and this is directly reported by youth. About 22% of Arizona adolescents enroll in 9th through 12th grade, have experienced 4+ ACEs. And then the most prevalent one was emotional abuse, which was reported by 60%, almost 60% of adolescents. As you can see, the categories are slightly different because there are certain questions that we were not able to ask the parents. Like this survey includes sexual abuse and emotional abuse. You can see that the next common one is household mental illness and household alcohol drug abuse. Like these are all prevalent as well. Compared to having 0 ACEs, 2+ ACEs can increase the risk of experiencing the following mental problems. So anxiety can increase by 340%, depression can increase by 510%, and then behavior conduct disorder can increase by 420%, and ADHD can increase by 380%. And this is after we accounted for the impacts of demographics. So child sex, parent sex, and the income levels and other demographic variables. And you can see the similar patterns of the results and youth-reported survey as well. So adolescents with multiple ACEs report worse mental health than those with no ACEs. The orange bars represent youth with multiple ACEs, and the gray bars represent youth with 0 ACEs. So poor mental health, like mental health was not good most of the time, or always, it was 61% among youth with multiple ACEs. And self-harm in the last 12 months was also very high among youth with multiple ACEs. The results were consistent for suicidal thoughts, suicidal plans, and suicide attempts as well. It was 28% for youth with multiple ACEs. Based on Americans' Health Rankings data, or their graph, the Arizona ranks 44 out of 51 for the percentage of children ages 0 to 17 years that experience 2 or more ACEs. So as you saw in the previous slides, Arizona children experienced significantly more ACEs than the national average. However, this is based on the National Conference of State Legislatures. So ACEs related legislation have not been enacted in Arizona. So at least 37 states and the District of Columbia enacted or adapted legislation related to ACEs. However, Arizona is one of 13 states that have not enacted ACEs legislation yet. I mean, this could have been changed in 2023, but as of 2022, we don't have that legislation yet. So what can we do? We all know the answer. The children need nurturing and supportive relationships and growth environments that could mitigate the impact of ACEs. We cannot 100%, prevent ACEs, but what we can do is mitigate the impact of ACEs, and we can help children with mental illness and also multiple ACEs by providing support and trust, like relationship, so that they can overcome their past and thrive in their environment. So positive childhood experiences are the opposite of ACEs, and then PCEs are advantageous and benevolent childhood experiences that promote positive development and resilience among youth ages 0 to 17 years. And these are 4 major categories of PCEs. So one of them is nurturing and supportive relationships. So this include having at least one adult at school or within the neighborhood or community who knows this child well and who he or she can rely on for advice and guidance. And also having family resilience. When family face problems, they can talk about the problems together and work together on solutions. And then the second one is living in a stable and safe and equitable environment. So living in a supportive neighborhood where people help each other out and watch out for each other's children, and living in a safe neighborhood environment where children don't have to worry about safety issues all the time. And opportunities for positive social engagement include participating in after-school activities like a sports team and clubs and other organizations, or participating in community service like volunteer work at school or place of worship, and you can name it. And then last not the least is the developing social and emotional competencies. So this can be developed through sharing ideas, or talk about things that really matter for children. And benefits of PCs are they are protective against ACEs, and then they result in better health and school outcomes, and then they can help children build resilience. So this is based on the literature that studied ACEs, the protective impact of PCEs. However, having multiple PCEs is less common in Arizona's use than the national sample. So based on the National Survey of Children's Health, having 4+ PCEs was only found in 47% of children compared to 50% of national average. And having multiple PCEs can reduce the risk of the following mental issues. So internalizing problems include anxiety and depression. So regardless of the demographics of children and parents, and regardless of the impacts, regardless of the fact that whether the children experience ACEs or not, internalizing problems can be reduced by 81%. And externalizing problems, which include ADHD and behavior conduct disorder, can be reduced by 72%. So that's a huge impact. So ADHS action plans, I would like to share this in the remaining time. So these are the 3 main goals that we have. First one is enhancing surveillance and data visualization on ACEs and PCEs. So we have ACEs website available that has a list of different surveillance dashboards on ACEs and PCEs, which I would like to share in the next slide. And then the second one is enhancing provider awareness of ACEs and PCEs. I believe that we have a team working on creating the provider videos to increase awareness of ACEs and PCEs that will be released in the near future. And then the last one is making ADHS a trauma-informed care agency, which Darlene will be sharing with you shortly. So this is the ACEs website. You can take out your phone and then scan this QR code. So we have the definitions of ACEs. It's got a lot of resources here, like state plans to mitigate ACEs. And we also talked about positive childhood experiences and dashboards. And we also included reports and presentations that we did in the past and additional resources to promote PCEs. So I would like to share, I'm going to stop sharing my presentation and I will show you this website. And just to walk you through like some of the dashboards that we have. Are you able to see my screen again?
Yes, we're on the website, Ben. Thank you.
Okay, thank you. So if you click on dashboards on the left side menu, it will give you a drop-down menu. So ACEs surveillance dashboard, ACEs surveillance dashboard for adults, and the ACEs root cause surveillance dashboard, and the PC surveillance dashboard and data sources. So if I click on one of them, it will give you this dashboard based on the National Survey of Children's Health. You can see the trend data, and then prevalence of ACEs in Arizona, and also the national average. And then if you click on one of these icons, so these icons are for you to see ACEs prevalence by demographics or healthcare needs and access, oral health, and children's health status, and family-related indicators, and school-related indicators. If I click on one of them, for example, like demographics, you can see ACEs prevalence by sex, age, race, ethnicity, household education. You can also see the prevalence of ACEs, like individual ACEs as well. And pretty much similar format for adults surveillance dashboard. So this is based on behavioral risk factor surveillance system data. So they also include ACEs questions. You can see ACEs by demographics here, and ACEs by health status and lifetime diagnosis. And another thing is root cause surveillance. So this is not specifically related to ACEs, but they are somewhat related to ACEs. So like the risk factors such as single parenthood and unemployment, educational levels and homelessness and things like that. And then these data sources are available by county. I just clicked on one of them and you can see homelessness by school districts. And you can also see the trend data as well. And you can also see the root cause dashboards, which is based on the latest literature that talked about root causes at community level, cultural, societal level, and family level that are related to ACEs. And you can see the explanations of how those factors are related to ACEs. And then PCE surveillance dashboards are also there. So you can see the prevalence of PCEs by demographics and health status, and also ACE scores as well. And last one is syndromic surveillance dashboards. So the population-based survey dashboards are the latest data set was released. I mean, that reflects latest survey data reflects 2021 data, but this one is more up to date. This is the real-time prevalence rates of ACEs. So hospital visits related to child abuse and neglect. And you can see the prevalence of that by demographics and county, and also trend data as well. And then the data sources are also available. So that's that. And then in that website, we also have reports that were published in 2021 and 2022. The first one is on adverse childhood experiences. And then the second one is positive childhood experiences. You can see the more comprehensive reports on those two topics. And if you if you are interested in looking at more, data visualization or more simple reports like in infographics, then you can scan this QR codes to see the ACEs and interpersonal support infographic, and then PCEs infographics. And you can feel free to share this with anyone who's interested in this topic as well. And this is my contact information if you have any questions about any of the data points or the ACEs website that I talked about. Thank you.
Ben, seriously, the work that you have done since they have brought you on is absolutely astounding. Bringing all of this data together in one place that we can go and we can see all of the different pieces to it, right? ACEs data is not just like cut and dry. There's so many different facets to it, and the fact that you've brought all of those facets together in one place for us to be able to go and look is really great. I think one of the questions that we get a lot of times during our certified trainer training is, why does Arizona have such a higher number of ACEs? And honestly, like being able to go to the dashboards that you all have created now to be able to see that, our PCEs are less than the majority of the United States. Well, that's why our ACEs are so much higher, right? Like we are able to correlate and look at root causes and pieces. And I think it's so great. I did put the links in the chat also for you all. And we'll be sending it with the recording and all of that. So everyone can go back. I think the one question that we received the most for yours was, will your slides be available? Can we share those?
Yes. Yeah. I will
Awesome.
share that with you through email so that you can send it out.
Awesome. And if anyone has any questions for Ben, please put them in the chat. We'll go to Darlene's and then we can do Q&A at the end of both of theirs. Thank you, Ben.
All right, thank you so much.
Awesome. Thank you so much for having me here with you all and connecting in the space, and just appreciate all the love that you're showing Ben. She's awesome. All right, so can everyone see my presentation?
Yes.
Great. We use Google Meet at the department, so I haven't used Google Zoom in a while. Let's just see, switching over. Okay. So as Angie mentioned, my name is Darlene Depina Shipp. I am a strategic initiative lead at the Department of Health Services. I've been at the department for about 5 years. Before this, I oversaw adolescent health initiatives such as youth mental health first aid, teen pregnancy prevention, and now I'm in the Office of Strategic Initiatives. And we mainly support agency-wide initiatives such as our reaccreditation efforts, continuous quality improvement, and strategic planning in general. So as Ben mentioned in her presentation, this Surviving to Thriving initiative, making public health a trauma-informed, healing-centered system, is part of our overall ACEs plan. So as Angie stated in the beginning as well, we took a pause on our action planning efforts. We started working formally on ACEs around that 2019 timeframe. And then once the pandemic was at its highest, we took a pause, but we noticed that programs were still undergoing their individual journeys on transforming their programs to better serve the people of Arizona and support their team members as well as the contractors through ongoing traumatic stress during that time. And so we regrouped and we incorporated this trauma-informed component into the ACEs action plan. So I'm here to talk about our efforts so far. And again, I'm sure all of you or most of you are aware of the different types of trauma. So I won't go into any of the physiology behind it, but I do want to level set and start with this big T trauma versus little t trauma. So over time, clinicians and mental health professionals realized the importance of why we should be recognizing and defining traumatic experiences into 2 categories. So big P traumas are just those events that are commonly associated with PTSD. And you can see some examples here, such as war or natural disasters, anything that are that's considered life-threatening, or even the threat of being harmed can be traumatic, right? And then little t traumas are highly distressing events that affect individuals on a personal level, but don't necessarily fall into the big T category. So what's highly distressing to one person may not cause the same emotional response in someone else. So the key here is understanding that little t trauma is to examine how it affects the individual rather than focusing on the event itself. But in both cases, big T and little t traumas, the individual may experience feelings of helplessness and hopelessness. And we also know there's vicarious trauma as well, but just want to highlight big T versus little t. And then I want to touch upon the workforce. So when we look at our workforce, as I mentioned before, there was a shift during the pandemic that focused not only supporting those that the department contracted with to ensure that frontline staff were being trained in trauma-informed practices, but ADHS internal staff also needed some support themselves. So staff, through various surveys that we had in the agency, reported exhaustion, experiencing burnout, compassion fatigue. So there was a lot going on that folks had to attend to. And so the question became, what is it that we can do to help better support the workforce? So we know that addressing work practices that contribute to stress and trauma is really critical to managing workers' adverse mental health. So when we look at, what it means to be trauma-informed, we look at, that increased team member engagement, employee retention in a workforce that overall feels supported and valued. And so what we know is that people's experiences, their past experiences really influences the way that any of us interact and perceive the here and the now. And so a key piece here of this trauma-informed approach is recognizing that, yes, people have experienced trauma, but if we look at the left-hand side of this diagram on the screen, we see that individual trauma is incorporated here. But there's also, we're recognizing there's also, historical trauma, racial trauma, institutional and structural trauma, gender bias as well. So it's the idea that all of these pieces of individual, collective, and historical narrative influences any of us in terms of, the here and the now. And those in healthcare professions, you all may be familiar with this practice, but just a show of hands on your screen or your reaction button, how many of you all have heard of the universal precaution or universal precaution? Just a show of hands or user reaction? No? Some of you? Okay. So essentially, if you take an analogy of going into a doctor's office and the medical provider puts on their gloves before any examination. So they're not necessarily asking, if you have a certain infection, this or that, they're just putting gloves on just in case. So when you think about trauma-informed care, really is that as individuals, agencies, organizations, like how can we put on our metaphorical gloves on in terms of being very intentional about the way that we're doing our work, so that we're not causing any type of re-traumatization and so forth. So what we're really thinking about here with universal precaution is that we can't, again, only think about individual trauma. We have to recognize that if you're truly going to be trauma-informed, there has to be intentionality about promoting diversity, equity, inclusion, accessibility, and so on, so that the world on the right-hand side that you see here is really the goal at the individual level, but also the organizational and system level. So, when we utilize what we're calling trauma-informed values and principles, you can see that happening. So just wanted to highlight that. And ultimately mention that trauma-informed approach is a fundamental change in way that the organization does business. So it's not just a matter of training, or changing a few policies. It's really changing the culture of an organization. And then some of you here may know the 4 R's as well. So there's many definitions out there of trauma-informed approaches, various models. But a trauma-informed approach essentially incorporates these, or they're guided by these 4 assumptions known as the 4 R's. So it's the realization about trauma and how it can affect people and groups. It's recognizing the signs of trauma and having a system which can respond to trauma, and then resisting re-traumatization. Which all leads to our definition here of trauma-informed organization or system. And it is an organization that has capacity and willingness to self-reflect, build organizational awareness, and seek to understand community narratives in order to respond in ways that do not unintentionally cause more harm. So trauma-informed system, what it's not and what it is. So being trauma-informed does not require individuals or organizations to fix what has happened to someone. Instead, it involves recognizing that we can't change what's happened. But we can, however, be intentional about neutralizing the environment to at least avoid that re-traumatization of individuals. Because of the way that trauma impacts the brain and the way that impacts people's sense of self and others in the world, the way that we do business can sometimes hurt people, and unintentionally, I might add, of course. There's situations that, for instance, like we could think about the policies that are created, the physical space or the virtual space that we operate under, what we're asking our staff to do if you are a manager or leader, the things that we can do may unintentionally cause harm. Thinking about maybe how you run staff meetings, are you inviting others to add to the agenda? Are you having places to check in with staff? to look at, the holistic person. Just questions like that is all part of the process. So again, we can't change the facts as individuals or organizations that people are coming into our spaces that have histories of trauma, but we can focus on what we can control to mitigate re-traumatization. So this brings us here, where so ADHS is wanting to operationalize how a trauma-informed approach can allow us to really look at our policies, procedures, and structures in order to neutralize that possibility of re-traumatization. So ADHS is currently using this manual, the Trauma-Informed Organizational Change Manual, and it's from the Institute on Trauma and Trauma-Informed Care, which is a part of the University of Buffalo's School of Social Work. So it's a comprehensive manual, and it's used to help organizations and systems plan for, implement, and sustain trauma-informed care. So it's organized by implementation stages and key development areas, and it's based on the SAMHSA's domain of consideration for organizational change structures. So the model includes organizational development components aimed at transforming both employee environments as well as the public environments that we interact with. And then also one thing to note here is that this transformation of being trauma-informed really requires a deep commitment at all levels. And because of this, it's estimated to take approximately 3 to 5 years. And I even suspect like longer for complex or large systems. So it's an ongoing process for sure. And we are just in the beginning. And I just want to point your attention here. This is a model that the manual uses, and it just provides a framework that will allow the organization using it to gain some insight and direction needed during an organizational change process. So, for instance, some of the 5 guiding values and principles may look familiar to you. It's adopted from SAMHSA again. So the idea that safety, trustworthiness, choice, collaboration, and empowerment, these key principles are really there for creating a workplace environment that respects people's experiences and manages the incidence of re-traumatization. There's a type of trauma practices. So there's different levels of trauma-informed approaches. I've added awareness here. I think that they've recently updated their model, but I couldn't find an updated diagram. But trauma awareness is all about, the education, the knowledge on the stressors, the adversity, how to respond with empathy and compassion. There's being trauma-informed, which is that overarching level, provides that filter for everything we do. And it turns that awareness into intentional action. And then there's trauma sensitive in the way that an organization or system responds to trauma and adversity. And it's all about making specific adjustments to practices and procedures and environments. And then trauma specific offers evidence-based or promising practices, trauma treatment interventions, specifically designed to treat and help individuals heal from trauma. All right, so just want to briefly go over kind of more of the components of the manual and how we're using it to guide our process. So the first component of the trauma-informed organizational model is identifying the stage. So there's 3 stages of the model. There's pre-implementation, implementation, and sustainability. And then within each of those stages, there's trauma-informed organizational key development areas embedded in each stage. So there's specific aspects of organizational functions that need to be addressed through a trauma-informed lens to really look at that organizational change overall. So I will go over these highlighted points in just a moment, but these are the 10 in all. And then from the 10 key development areas, there's each of those has at least one or more domains of consideration. So these domains are based on SAMHSA's organizational change model, and it's infused with trauma-specific content and values and principles of a trauma-informed approach. And essentially, these domains here ensure organizational change structures within each of the key development areas. So there's a lot that's embedded inside each of these points. So it can get a little overwhelming, but this might help visually in terms of the last 3 slides. So for context, the manual also has an organizational assessment that a group of us at the department were able to take late last year. And so this assessment, we were able to break down considerations for those 10 key development areas within each of the 3 implementation stages. So this really allowed us to have an opportunity to rate where ADHS as an agency currently falls for each of those considerations. And so the manual recommended that we look at the results to determine where it makes sense to start. And so we naturally, in a moment, I'll show you a snapshot of our results, move towards the pre-implementation stage to start off with. So during the pre-implementation stage, organizations really focus on preparing for and building a foundation of trauma-informed organizational change. It's really like the beginning. So you see here, we have the key development areas within pre-implementation, and then the domains of consideration embedded within those areas. So for instance, leading and communicating, you're looking at governance. So it starts at the top, right? It really means that leadership needs to embody what trauma-informed principles mean in their behavior, their day-to-day actions, decision-making, especially if decisions are being made at an agency level that impacts everyone. Then we look at hiring and orientation practices, and just involves how, looking at hiring practices, new employee orientation, how are those HR practices conducted in a way that's trauma-informed. Establishing a safe environment looks at our physical environment that the agency is operating under, and asking questions like, would a trauma survivor feel safe in this space? Whether that means as a public employee, a public individual or employee. Other questions would be, is there enough lighting in the parking space? Is the interior of the building inviting? Are there exits that are easy to get to? Or spaces that, people can go to if they feel overwhelmed? So those are some of the questions that are asked in this area. Collaborating with others looks at involving or creating mechanisms with partner organizations and systems like a system consortium to look at, what we are doing around in this area. How can we support each other's efforts in this domain? And then lastly, policies and procedures, or reviewing policies and procedures, is all about, when policies are developed, a trauma-informed principles should be considered. Does this policy promote and cultivate and embody what a trauma-informed practice is, or does it undermine it? So we can use some guides within this area to help modify or create new policies that are more aligned with trauma-informed practices. And so the core group that took the organizational assessment were made up of my office, the Office of Strategic Initiatives. We have our assistant director and deputy directors involved. We looked at professional development, community education, our facilities, HR, and overall leaders. And so what's highlighted is only part of the pre-implementation. So each stage has its own action items or recommendations. And it's supposed to continue, over and build upon each other. And so currently these are the owners, but essentially we have, cross references for different departments working on these. And then this was just a snapshot of our results for the pre-implementation only. So we did do an assessment for all the stages, but because we're focusing on pre-implementation, we wanted to look at where we needed to focus on more. So We even say now that looking back and doing deeper dives into the manual and resources, if we took the assessment again, it would be way lower than this. So, but it's still pretty much low. It's on a scale from 1 to 10. So we're pretty in the bottom, and it was expected because we just started, right? So looking at HR and our policy and procedures were areas that we definitely wanted to tackle first. And so this is just like a visual representation of our journey. So after conducting the organizational assessment, we share the results with the core team, and then split into work groups to create action steps for 5 key areas. So we were able to bring in others from HR and others from the professional development department to create tangible recommendations to move forward with. And then we completed our action plan at the end of June, so start of our fiscal year. We're now in implementation mode, so really excited about that. And then here are our recommendations. I won't go in depth with each of these, but again, you see the 5 key development areas under pre-implementation and some of the recommendations. So I just wanted to bring to your attention that, you know, for especially leading and communicating, we acknowledge that leadership buy-in is super important. But we also know that having a shared understanding of what trauma-informed practices is, and the awareness messaging is part of that as well. So we're really focused on, you know, ensuring that there's messages and presentations of what trauma-informed practices in public health looks like for the agency to level set. And then HR, we're going to look at how we can integrate trauma-informed practices into HR practices, like looking at interview questions and checklists. And also with our new employer orientation, embedding slides, you know, ensuring that, you know, we are working towards being more trauma-informed. Collaborating with others, we're trying to understand which programs within ADHS are already providing the trauma-informed programming and making sure that we're aligning efforts with trauma-informed networks in the state. And I skipped over establishing a safe environment. We're actually putting a pause. We're getting a new business administrator, business operations administrator, excuse me, so that we can get them caught up. But that is our facilities for establishing a safe environment. And then policies and procedures. We have a tool called Policy Manager that we use department-wide, and that's where we house all of our policies. So we actually have somebody right now just going through that and making sure that we are adding policies that are not applicable, or that is applicable to our work here, but also in general. And I'll note that a lot of these recommendations are tied into larger initiatives like reaccreditation. So reaccreditation is really honing in on health equity and being trauma-informed. So we are making sure that we're aligning based on what we have to do anyways. So it sounds kind of, you know, bad. It's like we have to do it, but let's make those connections so that others can see that this is where we are moving and heading. And then lastly, you know, as I mentioned, being trauma-informed is a huge, you know, focus for us, but also health equity and DEIA as well. So we're actually at the same time working on a DEIA plan. And so my personal, you know, wish is how we can merge our surviving to thriving and DEIA together, because right now they're looked at as separate, but essentially, you know, they should be connected, because we know that at the heart of this work, you know, trauma is at the heart of DEIA because of the repeated acts of marginalization, oppression, racism, wounds that, you know, really overwhelms one's ability to cope. So it would be a real disservice to address issues of DEIA without incorporating principles of trauma-informed care. So just wanted to add that there. That's something that I'm working on as well, bridging the two. But I might have gone over, apologies for that, but hopefully it all made sense. And if not, please feel free to contact me here at any time. So I'm just happy to be here, and thank you for welcoming me.
So exciting. I am so excited by all the work that you all are doing. And we've talked about it before, it's like turning the Queen Mary around in harbor. But y'all are doing it. And it is a slow process, because this is a large organizational change, and anybody who has even tried to implement trauma-informed practices in your own life, think of how long it took you as an individual to adopt trauma-informed practices across the board, right? Like it's a journey and there's not really like that kind of endpoint. It's always a constant work in progress. And then multiply that times, how many of our employees you have in an organization, and then the organization itself as an entity. And so it takes a lot of work, but having these conversations and doing the work that you have all done is really commendable. And really excited that you all are doing this. Yes, we will be sharing the recording of this and the slides from both of their presentations. But does anybody have any questions for either Ben or Darlene? Feel free to come off mute or put it in the chat. But are there any questions? Yeah, Jessica, I agree. Jessica said it's tremendous to see such a large organization embark on this work so mindfully. This was a great roadmap to help us see what is possible. Sabrina says, will this module base be shared to see if organizations can also take your wonderful lead? Yes, because we'll be sharing I'll share the slides, but also the link to the organizational manual that DHS is currently using to help them go through the process. Betty says, how can you encourage other agencies to follow suit? DES comes to mind. April is all over that. She's already asked if we're recording this so she can share it with her supervisors. But I think it's this conversation, right? And Darlene and Ben, Access is having this conversation also of what that looks like organizationally. And DHS being that kind of front runner right now, I think it's really going to come down to seeing it in action, right? And what is possible, and that it is possible, because it does feel like a huge task. April?
Yeah, I was just going to say, we've been working with DHS for the DEIA work. And so I was just saying to Darlene, wouldn't it be nice if we could, reciprocate and get some information on them, on especially combining that work. And I've been talking with our DIA officer about, don't forget, we need to include ACEs in everything we do. So yeah, I've been, me, I've been trying.
Yeah.
I'll keep
trying. But we're making progress though, right?
Yes.
Like we really are. I know that it feels slow to us that have been doing this for a while, but the fact is we actually are making progress, and that's why I was really excited to have Ben and Darlene come in and show us like this is progress. I mean, 2 years ago we could go and look at the data in all different sites all across. We didn't have anything specific for Arizona that was easily accessible and easily utilized, right? And we do now, right? We have a state agency who is taking concrete, actionable steps on becoming a trauma-informed organization. That is something that was not happening, you know what I mean, a few years ago. It was really just in that thought process. And so we are moving forward, which is so exciting. Bob?
Hi, Angie, and I hope I don't freeze. But I kind of think that, you know, there's kind of short-term game, long-term game. And it also feels to me like the opportunity exists to maybe force some structural adjustment in terms of the way you work with partners and the way you fund organizations and that kind of thing. You know, it's like, you know, you get to set the requirements as funders, and I kind of wonder if you've had any thoughts in that direction, short term, long term. But I know that the Governor's Office of Youth Faith, the trauma-informed verbiage in what they do with subgrantees, but I think also, you know, you're really going to have to develop a system where you see real evidence of progress in this direction. So I don't know if you can speak to that, or if you just, you know, want to move on to the next question, that's fine with me too.
Yes, Bob, thank you for your comments. And I think I completely agree. And doing this work, especially in a government setting, right, we have to look at what we can control and things and how to make things sustainable, right? So with our DEIA, with Surviving and Thriving, when we brought this to our executive leadership and, you know, try to get their buy-in and get their input, you know, a lot of them said, like, well, we're doing a lot of this in different programs. We're just not, you know, explicitly, you know, calling it DEIA or health equity or trauma-informed. But we have it in our vision, health and wellness for Arizonans. And, you know, we don't want to just call it an initiative or a project, because we know things that are coined that way tend to just come and go, especially with different administration changes. So things that we're thinking about with both our initiatives, especially with our DEIA health equity, is finding ways to change the structures that are us, right? So how our contracts are set up, how procurement works, who are we reaching out to. We have a pilot plan called, it's the Prevention Racial Equity Initiative, and it started in 2020. So we have a procurement and contract work group, and we've already made significant changes to wording and language, and our Office of Health Equity is working super hard on making sure that we're connecting with folks that we haven't been able to before. But it's a struggle and it's a continuous journey, but you know, I like to say that we're definitely moving in that direction. And I agree, we have to change the structures and the policies and procedures to continue sustainability and reach out to those who we haven't before. So.
Yes, thank you. All right, so we are going to move on to Dr. Amy Shoptaugh. If you have any questions for Darlene or Ben, you can continue to put them in the chat, and I can get them to them if they need to leave. But I do want to make sure that we have time for everyone. So let me remove these pins so they're not stuck. And have Dr. Shoptaugh, how are you doing today?
Good. How are you guys doing?
Good. And as a reminder, Dr. Shoptaugh is going to share on the trauma-informed pediatrician training that is available. You should have ability to share your screen.
You
also.
bet. Okay, is this everybody seeing the screen, Center for Resiliency and Wellbeing?
Yep.
Okay, perfect. So I don't think that I know you all. My name is Amy Shoptaugh. I'm a pediatrician. I've been in the Valley, gosh, for 35 years and used to own my own practice. And now I'm the medical director of this program that was started called the Center for Resiliency and Wellbeing, and it's at Phoenix Children's Hospital. Basically, the talk today will be about what we're doing to educate pediatric providers, clinicians, as well as even their staff and team members in the clinics. So we got a grant, the Maricopa County Public Health Department grant. And it started in August of 2022. And really we started the grant with a symposium in December of 2023 that I'll go into a little bit later. And the grant goes to December of 2024. And its focus is on how do we do trauma-informed care education for pediatricians and pediatric providers, as well as their support staff. We've put this into 3 different areas for the grant. One is focused on how do we educate pediatric residents, understanding that it's really important to kind of get it from the ground up to be able to diffuse out into the community. They're a little bit more ability to have changes. They don't already have set ways and understanding. And so how can we put that into residents when they go out, they can actually apply it and even change the systems that they go into later on. The next would be, how do we change the culture at Phoenix Children's and then the community pediatricians? So before we got this grant, we had already started to do some resident education. And starting about 18 months ago, we were able to officially put in formal education on adverse childhood experiences, positive childhood experiences, what is childhood resiliency, and what does trauma-informed care truly mean? So the first year we had already implemented 5 hours of formal education. That was with me doing videos. That was a partnership with the National American Academy of Pediatrics. And then the second year was 4 hours, again, with a kind of education basis with the National American Academy of Pediatrics. And then the third year was 2 years where we just did more didactics and patient education with a video of an expert going over how do we implement it on a clinical basis, and what is the importance of pediatricians becoming advocates for children and the parents that they serve who have suffered through adverse childhood experiences. Through the program and grant that we got with Maricopa County, this year we will be adding in the second year some education. And the education, and what I found what was missing is, you know, we educated about adverse childhood experiences, but the new studies really, and recent studies, are showing that it's not, again, what defines you, and it's not what really is the most important thing. You can't change what has already happened. So what are the positive childhood experiences we can do? What are those protective mechanisms and promoting mechanisms that we can do? And one of the biggest things is, how do we get to the parents? How do we actually get this parallel process where the physician, the pediatrician, is able to connect with the parent or caregiver, and then that caregiver take on some positive things that they can do at home, and then even build those resiliency skills with the children. So with that, what we decided to do was look at what is out there for positive parenting and strength-based education. And we partnered with a program at Mount Sinai, which is in New York, and they have a parenting education for residents, which is wonderful. And what they have is, the first section of it is a 4-hour set education basis. And the first is on the science of it. Why is it important for parents to really be able to do certain things with their children? What we call attunement, strength-based, finding out what is the positive, talking about time in versus time out. What are things like self-efficacy? What is secure attachment? Those kind of things. And what is the science based in the mind and the development of the child's brain? And then the second part of it is on, now that you know the science, which is wonderful, how do we now apply those science principles into the clinical application? You know, like Dr. Shoptaugh, I understand that you're saying that this is, trauma-informed care and ACEs are important to understand, but I'm not quite sure I have this child that has all these issues going on. And what do I do when that patient's right in front of me? And so this is actually, how do you clinically apply it? And then what we added into this afterwards is that the didactic. So after they do the 2 hours of science of the education, is we meet with these residents for an hour, and we go over a patient case and do a question and hour section. And that would be after the science part and then after the clinical applications. We added 5 more hours into the formal education of residents. So we now have 21 hours that have been added into the pediatric residents, which is just pediatrics, but it's also the med peds. So they go into internal medicine and pediatrics that actually go through, and any medical students that might be in that rotation as well. The next section would be with what are we doing at Phoenix Children's? How are we implementing and changing the culture to become trauma-informed? And what our contract is basically with providers. So the first thing we looked at is, well, if we're going to teach residents about positive parenting, then we really have to have it that the attendings that are overseeing the residents, what education are they having, and being able to talk about these topics. These residents can learn about positive parenting, but if it's not discussed and really emphasized in the patients that they're seeing, then they're not able to apply it, and it becomes something that becomes ingrained in what they do. So what we're doing with the attendings at General Peds, and we've partnered with Phoenix Children's as well as Valleywise and St. Joe's, is we're doing monthly emails with themes based on the Mount Sinai education. And so each month we have a theme of things like secure attachment. And we do 1 or 2 little sentences to make it really easy for them to look through. And then we have attachment that actually goes over why is this important? How do we implement it? And what's the thing you can focus on in educating the residents? So that's real important. And then what we're doing is, this is a QI project, is we're doing a pre-survey. We're doing in the middle of the year survey of how is it going. And in the end is the post is what you're learning. And we'll go over what those questions are. So the website looks a little bit like this. It's called the Keystones. And the initially starts in the classroom, the science behind it. And these are the 6 main areas that they look at. What is secure attachment? What does autonomy mean? Self-regulation, the importance of the child being able to regulate their large emotions. Perspective taking, problem solving, and then academic knowledge. And then the second part is the exam room of weaving principles into the clinical exam visits. And then, this is out of place, but I'll go back to this, the survey that we used. We also have at Phoenix Children's have implemented what we call lunch and learns, trying to get physicians to put some more learning into their day-to-day when they have so much going on is real difficult. So what we've done is tried to implement this education during the lunch hour and to provide free CME. So we're providing a lunch, we're doing CME, and it's over a 50-minute period so they can get it in between patients and be able to sit down, eat lunch, and still learn this. And the title is Trauma-Informed Care for Providers. It's going to be 3 cohorts over the next year, and there's going to be 2 sessions of it. One is just the general principles of trauma-informed care, and then what can you do as a provider, no matter what specialty you're in, to implement it in every patient that you encounter. It might even be the essence of teaching your medical assistants to ask for the child, which arm do you want me to check the pulse ox on? That ability to have some choice in what their matter is. It might be talking to the physician about when you come in the room, the first thing you look at is the caregiver and the child, not your computer. So it's these general principles that they may be doing already, but how is that implemented into the appointment to make that child and that parent feel secure and safe within that appointment to be able to have a partnership with them. The next would be registered nurse education, because we find that this is important. The nurses within Phoenix Children's really are on the floor with the children and the parents and kind of are the voices and the eyes for many physicians. So we feel that if they're educated and they grasp on to the principles and understand how it makes their work more enjoyable, then the hopes is they're going to push that to go forward to wanting to learn more and the attendings will be wanting to learn it as well. So we're doing some lunch and learns for them. We've spoken at the registered nurses symposiums at Phoenix Children's to educate them as well. And then we've also, through Child Life, we understand how important it is for the children while they're there and admitted is to have a safe place to go. One of my colleagues has this beautiful saying that says that fear decreases play, but play decreases fear. And so if we can implement Child Life into it to understand that when they go there, they can do maybe one of their hobbies, they can get into playing, it decreases fear, not only helps with the healing, but also gives them some efficacy while they're at the hospital and actually allows them to have some joy when they're there. So that's an important part as well. The next would be, the big part is, how do we go out into the community and educate pediatricians and pediatric providers? And so what we've done is we've developed a trauma-informed care education series. It's a set of 4 one-hour sessions. It's actually 50 minutes. And the reason for that is that when we do these education sessions, it can be 1 CME credit for each hour session. So we developed a free CME. And we've been trying to do it in different ways to try and really get physicians to come. So we first tried it during the lunch hour, which turned out pretty decent with St. Joe's, but it was very difficult that if a provider was seeing patients over the hour, they would come in the middle of it or they just wouldn't show up. And so now what we've been trying to do is doing it in 1 day and a half day and getting their leaders to give them the half day off as CME to be able to come to the program. We're also looking at putting this into embedding it within the internet and developing pre and post questions so they can get CMA as well and they can do a self-learning. So that will be the next step that we do. We've also offered to come to their office and help support how do we implement trauma-informed care clinically in there, all the way from answering phone calls to what are the front desk people doing up front, what does the environment, what should it look like, what makes a space feel safe, to the medical assistants who bring the patients back. And then how do we work within their EHR, developing templates that can actually be put in there, and what are some basically scripts that physicians can use that help them feel comfortable of why are we doing a screening and why are we referring to certain areas to be able to help these patients to get the help that they need. And so we're doing that as well. We've also developed a way for them to, on the internet, to get resources in the community that we have partnerships with. So if we need something like utilities, they can go onto this sheet that's internet-based and be able to pull up numbers for the ability to go out and get resources, food insecurity, domestic violence, places for short-term therapy, YMCA, Boys and Girls Club, just some resources for these places that they can go to. And then lastly, what we've done with this is to develop, is this something that they feel it's important? Do they feel comfortable in treating children who have had adversity or major trauma? So we developed a pre and post survey that they do, that they actually have an incentive to fill out, and will be at the end of the year being able to tally up the results to see if there's been some education that's been attained, and do they feel that this education has been important. We've also, the cohorts that we've done with this, we've already educated St. Joe's general pediatricians, partnering with Valleywise, and we're in the setting it up now with a large community pediatric practice with over 40 practitioners, trying to set that up for the end of the year to do these 4 one-hour sessions. The next would be I'm sorry, and I got this wrong, 2022 symposium. I got the years mixed up. Last year we did a 2022 symposium. There were over 100 attendees, had a good turnout, and it was a half a day. This year in 2024, it will be a full day symposium, December 5th. So keep it on your calendar. We just got the flyer permission to use through Phoenix Children's as of yesterday. So I'll send this to Angie and hopefully she can send it out to everybody. It again will provide free CME. It is going to be 8 presentations, so it'll be 8 to 5 o'clock. It will be virtually, and the agenda will start all the way from the beginning of the early brain development, starting in utero. We'll have a developmental pediatrician to talk about early brain development and why it's important to understand these sensitive and critical times and how adversity actually, what are ACEs and how does adversity affect the brain and body in a child during these sensitive and basically very critical times. The next would be a topic that's near and dear to my heart is this now connection of psychoneuroimmunology. Sounds like a larger word, but basically it's how the mind and body connect and how what happens in the mind affects the body and what happens in the body affects the mind. And you get into this bi-directional that cause chronic inflammation in the body that actually causes inflammation in the brain that sets the point for the stress response to fire certain chemicals and hormones in the body. And it also changes the set point for the rewards in our body that actually makes people more prone to having some possible addictive tendencies. And so we'll have a specialist that talks about that as well. And then we talk about integrated, the physiological as well as mental health embedded within the clinical practice, as well as integrative care. The integrative care would be complementary. So things like breath work and meditation, self-compassion, self-efficacy, where does that come in and how does it affect the stress response to calm down this inflammation and the stress response hormones and chemicals? The next would be about what is the affiliate response? What is this response that is the other side of the coin of the flight or fight response? And what is the antidote to adversity and things that children experience that are negative experiences? Is what are those connections? What are those relationships that they're having, those positive experiences that allow them to basically get over this adversity, as well as develop the skills of resiliency to handle things in the future. The fifth talk will be on strength-based care and what is positive parenting, and that will be somebody from Mount Sinai. Transgenerational ACEs, the importance of parental ACEs, how that comes into picture when pediatricians see the child. It's not just about the child, but what does the parent carry with them and basically the lens of the world and what kind of parenting they give to their child, and what those positive childhood experiences are. And then lastly, it'll end with the clinician taking care of the pediatrician. What are the things that the clinician is doing self-care with their own stress response, self-compassion, and then what they should be asking from their organizations to have support as well to help them to handle not only secondary trauma, but even to basically help them to be a partnership with the patients that they see. This was supposed to be in earlier. This is our pre-survey for the Mount Sinai for the attendings with the residents. So the pre-survey is a 5 questionnaire, basically says, do you believe that education on positive parenting is important? What is your current comfort level in providing counseling about positive parenting? What percentage of well checks do you give positive parenting and history guidance? What are the barriers to that? And what aspects of the positive parenting skills would you like to learn? The post screen is almost exactly the same, but instead of what aspects of skills would they like to learn about, but what have you learned over the year that you actually now are going to carry forward and continue to teach within seeing your patients and with the residents. So this is basically what we're doing with the Center for Resiliency and Wellbeing at Phoenix Children's for education for physicians, pediatricians, and the people that they have around them. Any questions for me?
I'm so thankful for you all and the work that you are doing around pediatricians. You know, in the chat, they were talking about, you know, having programming for 0 to 5 and how it's not inclusive and across the board, right? All parents. And I really do think that pediatricians are that key, right? For that 0 to 5 space specifically, because a lot of parents will be taking those kids to their well checks and all of those pieces, right? That may kind of taper off as they get older and into pieces, but as children, the youngest ones specifically, you know, pediatricians are that one source of information for them across. I think a question that I have, and if anyone has any questions for Dr. Shoptaugh, please put them in the chat or raise your hand and you can come off mute. Is how do they get the information about what you are doing out to other pediatricians? In the chat, I am going to put your grand round with Dr. Forkey that's coming up on August 29th, but how else can they become a part of the trainings that you do for the pediatricians?
So we are doing, and I didn't put that in there, but there will be a grand rounds through Phoenix Children's on, I believe it's August 29th, 7:30 to 8:30. It's a Tuesday morning. It's with a physician pediatrician that's really probably one of the top experts nationally of trauma-informed care for pediatricians. Her name is Dr. Heather Forkey from UMass. If anybody's interested, I'll get that out to Angie. You can just join the Zoom and be able to listen to her. It will be recorded, but I don't know how to get that. And so if you're interested in the future, just get with me and I'll try and find out where you can get the video of it. The other is I have a flyer for the symposium that's coming up on December 5th. So I will get that out to you, Angie, and you can put it on your site to get out. And then the other would be for any pediatrician to just contact me personally of what we're offering.
Awesome. And I will share Dr. Shoptaugh's email in with the recording and all of those pieces too. Are there any questions for Dr. Shoptaugh? Thank you for taking time out of your increasingly busy schedule to come. I just, you know, we talk about like nothing's going on, but there really is a lot of things going on. I think it's just part of the reason is we're not highlighting it, right? And we're not connecting pieces across. And the work that you all have been doing at the Center for Resiliency and Wellbeing is amazing, but it's one hospital, right? And so like, I love that we're now able to bring this education across and to other pediatricians, and you all knowing how hard it is to get education in, because, you know, the doctor and nurse schedules are just, they're just unbelievably busy. So thank you so much. We'll move that pin so face isn't all big. All right. Whew. I am super excited. I don't know what you guys, but I like seeing what is all going on. And so now we are going to move to our committee and partner updates. Make sure that we have, I don't think Jennifer is here for our trauma sensitive schools. Let me see.
I'm right here, Angie.
Oh, there you are. Hi, Jennifer.
Hi, good morning.
We'll have you go first if you don't mind.
Not a problem. So just giving a quick update for our trauma sensitive schools group. We just kicked off this school year at the beginning of this month with a presentation that did a lot around self-awareness with Carl Johnson. So we're in the middle of a 2-part mini series with him. So we're really trying to start this school year off by giving all of our attendees, educators, those that work with students or have some impact in schools, some of the resources and tools for themselves to kind of recognize the needs in a classroom, how to provide some prevention, how to provide some support And so we got a lot of really good feedback from that first part of the mini series. So I just want to extend the invite to everybody in this group, and please feel free to share for the upcoming training, which is going to be the first Wednesday in September. It'll be the second part of the mini series, and this portion of the training is really something that's been well received by schools and school partners in the past, as far as really looking at what the needs of a child might be, where the challenges that they're displaying in a classroom are coming from, looking at it through more of a trauma lens, and then also, again, helping with some of those ways to help prevent some of those behaviors and outbursts or disruptions in the class, and also ways to respond to them in a more trauma-informed approach. So our second part is the Invisible Backpack, which is a really phenomenal training that's been well received, again, in several of the districts in Arizona. And so we invite all of you and anyone that you want to extend the invite to join us that first Wednesday in September.
Thank you, Jennifer. And I put the link to register for the work group in the chat. That is a recurring link, so you will be registered for all of for the whole school year, for every month. And then I will put also the work group page, because all of the recordings are posted on that page, and so you can go back and watch Carl's first part of the mini series if you are interested, also before going to our next one. Thank you, Jennifer.
Thank you.
Renee has just recently, as of yesterday, started our rural and indigenous community group, and I would love if she was able to give an update. She might have.
Yep, I'm here.
Perfect. You moved on my participant list.
Yeah, they do the shuffle. Yeah, so it was great to meet with some folks. I think we had probably 20 plus folks joined us, definitely from across the state, which was fun. Did some introductions, saw if there were some relations in the among the participants. And moving forward, really I started with, what resource can the ACEs Consortium provide to rural communities? So really setting up this group to be a liaison from rural to the consortium, and the consortium to rural, and with the hope that some of the messages coming from rural also get to state groups that Angie and others are a part of. We kind of brainstormed how the group could be most useful. And I think initially they'd like to just do kind of like a resource or best practices. So what each district or person, whether they be medical providers, within school systems, within nonprofits, within state agencies, what are they doing that is resiliency building in their organizations. And so we'll have work groups and have folks share those ideas, and those are ideas that we can also bring to the consortium or share with the consortium. It was a short and sweet meeting. We just wanted to establish why we were together, who was in the group, and what our next step would be. So our next meeting, we're going to keep it for the third Wednesday of each month from 12 to 1. So it'll be September 20th, 12 to 1 via Zoom. I can put a link in the chat. Angie, the first one was not recurring, but I created one yesterday that is, so I'll make sure to get that in the chat. Last thought, sorry. I am trying to create a contact list. Many of you might already have one that's similar, but with at least one contact in each county and one in each tribe. We have a couple of intertribal members, so I'm going to reach out to them about the tribes. But if we have a contact in the following counties, I'd love to have a contact, one that's really focused on resiliency and resiliency practices, Apache, La Paz, Mojave, Pima, and Yuma. So I can put that in the chat as well, but those 5 counties I'd love to see representation of.
I have Apache, La Paz, Mojave, Yuma, and
Pima.
Pima. Oh, I have contacts for you for Pima.
Great.
Yep. I put needed the counties in there. So if you'll just share the link for the registration for the rural, and then I'll also get that out in our replay.
Great.
Sabrina for communications.
Hi, I just want to say, wow, that was so much information and amazing work that's being done, right? So I probably after this meeting need hours to process it because it was a lot. But I am Sabrina, I'm the communications committee lead. We don't have too many updates. We're just continuing to grow. We've had a couple of new members join, so we are always open to anybody that does want to meet. Right now, we meet either the first Wednesday or the second Wednesday of the month, similar to Renee said for her group, and it is around 12 o'clock as well. So right now we're meeting from about 12 to 1, and ours is a reoccurring link. So I can put that in the chat, Angie, or if you can put it in the chat, either or. And right now we are really just creating ways to communicate through social media. So right now, social media is our big bridge. And so through communication, we do have a newsletter. It comes out bi-monthly. Recently, I think it just came out for August and September. So a new one will come out in October. It usually is posted, I think through an email, as well as most recently, I think it was attached to this community of practice email that was sent out. So if you didn't see it, check it out. And then what we're trying to do is make sure everyone can follow the social medias, because with social media, it only works if people follow and share, and that's what we're trying to do. So we're trying to get a little bit more action in that. So right now we are posting a lot of self-care stuff, things that have to do with awareness, understanding of, some facts around ACEs and stuff like that. Little things on Facebook, Instagram, LinkedIn. We haven't yet done a YouTube video, but that is our next step, is to repost and share YouTube videos. And so that is our goal right now. And that's all I have.
I love it. Thank you. And we do have a YouTube channel, and in our follow-up email, we'll make sure to have, we actually have a page. Our website is down for capacity issues for some reason right now, probably because I'm sending everyone to it, but we do have a page on there that has all of our social media links. That is easy to go through and be able to follow them, but I will make sure to send them out to everyone. Sandy for a training work group.
Good morning, everyone. I'm with Sabrina. My brain is so full, and I'm so excited about all the things that are happening in Arizona right now. I know sometimes on the national stage, we don't often come off looking really great. So we can kind of lose that perspective of all the amazing work that's going on here. So it's just really incredibly exciting. So this year, the training work group has been focusing on trainer support, certified trainer support, based on the feedback that we did for all our certified trainers back in February. So aligning with that, a couple of pieces of feedback that we heard was, and to Betty's point, I don't know if Betty's still on the call, people want to be in person. They are creating those in-person gatherings. So the work group got together and talked about informal certified trainer community gatherings. So small groups just coming together to support one another, small groups of trainers. So based on that, we did a quick test and learn in April, and a big thank you. I don't know if Jeremiah Kaplan's on the call, but Jeremiah and ASU CERC hosted that, and we had, I think it was 7 or 8 of us that showed up. We drafted a gathering guide, so just some really loose ideas and things that that might be helpful to folks wanting to pull trainers together in different areas. We've finalized that over the summer, and we're starting outreach to folks across Arizona. to see who is wanting to pull certified trainers together. Again, just support. It can be more formal, like you do, your own professional development, or just people sitting around having tea or coffee or water or whatever, and just talking about, the things that you need, supporting one another and building those social connections. If you're interested, please feel free to reach out directly to me, and we can send you that guide and talk about how you might want to pull some certified trainers together in your area. Our next certified trainer community of practice is going to be on September 7th. I almost said September 11th. I'm losing my brain. September 7th at 11:30. I put the registration link there. And what we're doing this time around is kind of a mini conference format. So we are going to have a variety of topics. Some of them will include, but not limited to, more information about neuroscience and how to support trainers in presenting that in your trainings, trainer resilience and compassion resilience, more information about healing-centered approaches, which is something new that we added to our curriculum. And I have heard a lot of trainers requesting some more support in learning more and how to present that. We will have a small breakout, or we will have a breakout on talking through or talking about convening some of these small gatherings, these community gatherings of certified trainers. So we'll have that information there, some information about mindfulness presented by our wonderful Sang-Hoon Yu, and then adding fun to your trainings through activities. So that's what we've got now. We'll probably be adding 1 or 2 more. So you can come, it'll be very informal. We'll have about 3 rounds of about 40 minutes. We are extending the time. We typically do 2 hours, but we're gonna have this on September 7th. It will be 11:30 to 2. And any portion of that time that you want to join is perfectly fine. If you can't make it at 11:30, come when you can, leave when you need to, and take in whatever information you need, information and support. And finally, our last training of trainers starts September 19th. Angie is going to pop the registration link, we hope, in the chat. We do still have some openings. So if you're interested in becoming a certified trainer, please hop on there and register. It starts September 19th. It's 5 weeks every Tuesday from 9 to 2, with a lunch break from 11 to 12. So September 19th, every Tuesday for 5 weeks, 9 to 2, and you'll learn all sorts of good stuff. I think that's it. If I forgot anything, let me know.
I was typing the link into
Yeah.
the chat again. No, perfect. Thank you. And again, we'll have all of the links in our follow-up email. Sang-Hoon for the Interfaith Committee and Arizona Trauma Informed Faith Network. And I will stop sharing because I believe he has slides to share himself. Hey, Sang-Hoon.
Okay, Hello, everyone. Hello, Angie. How are you?
Good. How are you?
Good, good. Hi, Sandy. When I only see Angie and Sandy here in my screen, looks like wearing the TOT training, so I'm confused. Hello, everyone. This is Pastor Sang-Hoon Yu, founder of Faithful City, and also Arizona Trauma Informed Faith Coalition. Last week I did a local national kind of presentation about our project, so I have some slides I can share here. Well, if you are interested in our interfaith committee meeting. It's gonna be next one, gonna be September 1st, Friday, 8 a.m. And I'm just typing right now that my email address. So please contact me so I can send you the Zoom link. If you go to our website of Consortium, we're gonna still talk about the Tuesday, but we moved to the Zoom meeting and typically first Friday, 8 a.m. But based on all our condition situations, then we just move around. That's why I appreciate if you can send me an email about our meetings. And also ACEs Consortium, Arizona Trauma Informed Faith Coalition, and the Faithful City, and we are doing work together. So it's very hard to separate from our history of origin. And now I'm working also with county public health, like ACEs Consortium work together. So I sometimes apologize to people because people are kind of confused. There's so many things going on, but actually, that's why simply just you email me and we can start our relationship and also kind of discussion, so we can kind of work through the where you fit if you want to work with the faith community. It was funny that today when Bean and Darlene in talking about their trauma-informed agency system, and because yesterday I was talking to April that hey, does AZTIFC is trying to the trauma-informed agency. How about DES? And when I came to the meeting, and Angie put everybody together here, so like I was laughing hard. It's so funny. The reason I'm saying this is that you may rarely hear that the collaboration between the government and faith community, but we are making a very national model, because our grant was one of a few or 2 or 3 of a CDC grant through the county public health, supporting the faith community in the whole nation. So it's a small grant, but it's very symbolic. And if you are part of our movement and project together, you can be really proud of what we are doing is a very phenomenal, like all other presenters do today, as well as ACEs Consortium. So again, it's not separable, you know, so I just kind of, we're all one body, I feel like. So with a lot of development of our coalition, we continue in our key congregations and meetings together. And actually, one of our branch is, our branch is a Tucson, and Phoenix, we usually had our statewide conference, and Tucson has their own regional conference too. Now it's called the Reclaiming Hope, and it's gonna be next month on September 9th. And September 8th, Friday, I'm sorry. And if you wanna be part of it, let me put that registration, the link there. So if you are interested and you can be part of the conference, you can come down to Tucson. They have a phenomenal collaboration with the faith community and school and all other social service and health areas coming together. It's like what we are doing in the Phoenix area and also statewide. So I'm very proud of Robin and Blumenthal and what she has been leading and the cause in Tucson area. And also, again, I'm the co-manager of the PACES Connection Faith Community nationally. And also we are chairing that CITIP community of a practice of faith part. So we are really working with our local national community together. And just last week, the Grace Association in Minnesota, that's a godly response to the, against children abuse in Christian environment. They just did a trauma-informed care training, the executive director and then and the board chair. I'm part of the board there, and then we had about 300 people coming to listen to what trauma-informed church means. So now is kind of really getting into the faith community theologically, but also in a lot of ways that the faith community is really nationally getting attention to the trauma-informed care. And with the public health, county public health, and we started a project creating community of belongings. So with that, the goal is a substance use awareness and prevention, but it's totally trauma-informed care lens-based. So with all this project, we made a curriculum. So with the trauma-informed care, substance use, and community of belonging. So reducing the stigmatization and building the safe place. Well, basically, it's not about just a political or kind of a theological word. By brain science, when we have a sense of belonging, we feel safe, which is a foundation of a trauma-informed care starts. So the belonging means that we create a belonging community based on our sharing, not only substance use, all our struggles together. And so we can really see that I don't have to be perfect to be in this community, but also I get aware everybody's struggles. And so with this training, and we also do the follow-up with the people, with the senior leadership together. So when they really try to make a systemic and cultural change, not just to treating the people as suffering and struggling, but when we open up our sharing, so we really building safe community. My definition of safety is not about what not to say, what not to do, but it's about continually sharing difficult our dialogues and struggles, but we still feel safe. That's why we need a certain training of mindset. And that's what the training is about. For the first part of the year, we trained about 100 people from 35 organizations. And this weekend, we now have a Spanish version. So we're gonna have a 16, the senior leaders and pastors gonna be trained with our Spanish version of the belonging, community of belonging. And so with that, I think you know that I've been doing the podcast with Michelle. The first season was the journey on about all our AZTIFC Consortium movement. So if you look at listen to all the episode, you can hear all the stars there of our movement. Well, don't get me wrong, if you're not there, you're not a star. I'm not saying that. So don't get me wrong on that, but I'm really amazing the colleagues of the movement. And the second season is really talking about our being and belonging. And so, and also you can also enjoy the conference keynote speakers conference. So we had a Weave and Cleave conference, which is kind of a new branding of our conference in the Phoenix area. And we had the keynote speakers, and also we had 11 organizations award from County Public Health and our Faithful City together, who've been through the training and also continue the following up to change their culture. So we have 11 faith-based organizations who really received the award, and we still keep working. And there are so many stories that what's going on with all our movements. So hopefully you can be a part of the movement together. And I have a 2 minute and 30 seconds video. I will try to play, and if it doesn't work, and Angie just kick me out, okay?
We're here to deal with creating communities of belonging in a very disconnected society.
There's been just a lot of economic fallout, substance use disorder, eviction crisis, folks experiencing homelessness.
Was trauma around my family? Yeah. But are we breaking this generation curse? Yeah. And the hardest part, I realize it has to start with me.
God is more than able to use the good, the bad, and the ugly of your life to make a massive difference in this hurting world.
You will meet people in some of the most vulnerable places when you're doing trauma-informed work. And it is a blessing to meet them there. And it's hard, and it requires relationship, and it requires time, and it requires us to break down stereotypes that dehumanize one another.
through this, my self-regulation, my self-healing, my relationship with our lead pastor, you know, just walking that path, then walking someone else through it, right?
I saw the amazing power of the faith community and how the faith community can really come together and address community issues.
Through conversation, we realize we're really not that different, and we all do need to work together for a common good and a common goal.
We need each other. We belong to one another. We need to encourage each other and build each other up.
There's resources and trainings here, but there's so much that everyone can learn from each other.
We see a lot of connection, not as a business interest, but actually genuine support. I'm doing this, and I find a friend and colleague, we can work together.
I really love the diversity of religions that we are, and to appreciate that diversity has the treasure of our society, because together we can make better everything.
We can be catching everything as it's coming downstream, but if we don't go and plug the whole upstream for what is happening to harm our communities, it's going to keep happening, and eventually that flow is going to overwhelm us.
We are in a state where we need to be able to pause, reflect, and build better systems that promote better outcomes.
Now, the task is monumental, but at least this is the beginning.
Training is done, conference is done, you got a certificate. But no, this is not the end. This is only beginning. So we had the interfaith panel, which was fascinating to everybody. So people think do the trauma-informed care with the faith community not possible. Well, it is possible now. People think a faith community cannot work with the government. Well, it's going on right now. And people think all the faiths and the government and social service come together in the kind of harmonious way to work together. They don't think it's possible, but it's going on now. And we are preparing next year project and conference in May. So I hope you can join us. Thank you.
Saying that video was absolutely amazing. And I would love if you have a link of it, or if you could just share it with us, we can put it on the website and on the Interfaith page too, just to help with everything. So I know we have 5 minutes left. We have a whole bunch more announcements and things that we will not be able to get to. However, I do want Bob to be able to do the board updates, and all the rest of the announcements I will put in the chat. I will also send them out in the recording. Thank you, Sang-Hoon, and I will make sure that gets out also. Bob, I'm going to pass it to you to finish us off.
Thank you. 4 minutes or less. No, Sang-Hoon, I thought that was a really great video as well. And I appreciate all of the volunteers for stepping up to lead our committees, which, you know, really advances our work. And something I would love to ask everybody who's still on the call to, on a scale of 1 to 10, can you rate your satisfaction with being a member of the consortium? So just type into the chat, you know, how do you think we're doing? Seeing some positive numbers there. Keep it going. There's more than 5 people on the call. Right on. So there's a couple of things that I think are really important and valuable that I would thank you, Richard, for the 8.9. But there are a couple of things that I really want to presence and acknowledge here is the crazy, remarkable work of our staff and volunteer leaders and all of the folks who've become certified ACEs trainers, you know, the advancing the work of childhood trauma and awareness of childhood trauma and response to childhood trauma in Arizona, I think really can be credited to this, increasingly sizable group of people, and the influence that you all have is just, I think, pretty remarkable. Are there more slides of annual report? Angie recently put together just some interesting data points for our consortium, just accomplishments over the last year. 126 trainers trained across multiple states in Puerto Rico, so we're getting that national presence. We have the Resilience Empowerment Project that has trained almost 800 educators in 32 schools, started indigenous community trainings. It's just pretty remarkable, all of the things that are happening across the consortium and across the project. So a big part of why we are where we are is because we have an incredibly dedicated another group of volunteers that meets on a monthly basis, that really works out the organizational and the business operations and kind of the structural component of building this plane as we fly it, building the consortium and, working to strengthen who we are and what we do in the state of Arizona and in the country and in the world, I suppose. So currently we have a really remarkable board of directors for the consortium, and we currently have 4 open seats. Specifically, we're looking for folks that can do fund or business development, have that kind of experience. However, don't let that limit you. If you really feel passionate about serving at the highest level of this organization, if you feel really passionate about really making a significant contribution to advancing the work of the consortium and elevating the importance of ACEs and trauma-informed care in Arizona, please, please, please feel free to put your name in to serve as a member of our board of directors. I will type in my information in the chat, my contact information in the chat. So I can't talk and type at the same time. So
I can do it for you, Bob.
Okay. And add my Angie, add my cell phone. So you can reach out via email, you can text me, you can call my cell, and I'd be more than happy to talk with anybody and everybody that is interested in serving on our board of directors. Again, we're looking for 4 great people. And I know that we've got at least 37 really great people on this call. And I think we'd be happy with all of you. Well, maybe not all of you. That would be like a multi-party system like Italy or something. But anyway, really, I think that, service on the board is a really remarkable opportunity. And we get to work with Angie on a very regular basis, which is always a great privilege for all of us. And I think that's it. So any questions, thoughts, or comments, folks?
I know that we are 2 minutes over, but it's really important that we know that we are doing board elections. The nominations are going to be open until September 13th. Please feel free to share it around. I also put the link in the chat. I put a lot of other resources in the chat also. You're more than welcome to save this chat. You can click the 3 little dots in the chat box that you see, and it'll say save chat, and it'll save that to your computer, so you'll be able to get all of these links and those pieces. But Pima County is doing a Celebrating Resilience Summit in October. That information is up there. The Birth to 5 helpline has an awareness week that is there. And then there's also new program for grieving families and parents, for bereaved families program. That link is up there also, along with those pieces. One other thing important, I'm going to be sending a link on our educator survey. This is a control group that we're doing. So if you are an educator, if you have educators in your network, if you could please send those links out to them for this survey specific. This is only if you're not a part of our Resilience Empowerment Project, looking to kind of get a baseline control group. Letting you know that our summit is coming up December 4th through the 7th, and our workshop proposals open today. So I will be sending that info out also. And we hope to see you November 16th. And thank you for hanging in with us, especially 4 minutes over 2 hours is a long meeting. And we really appreciate you being there. If you have any questions, please feel free to reach out anytime. Or put them in the chat, and I will stay on for a couple minutes longer. Thank you all.